I'm now honored and humbled to present to you Dr. Duncan Maru, who is an associate physician at Brigham and Women's Hospital in the Division of Global Health Equity, as well as an instructor in medicine at Harvard's Medical School. In addition to his work in these roles, he is also the co-founder, chief strategy officer, and a non-voting board member of Possible, which he's about to tell you more about, so I'll leave that up to him. His research focuses on using implementation science research methods to improve the delivery of evidence-based healthcare interventions in settings of extreme poverty. In 2013, he was named a Young Star in Global Health by Grand Challenges Canada and a 2015 Social Entrepreneur of the Year by the Schwab Foundation. I could go on and on about these accomplishments and his degrees, but instead, I'd like to add a few things that you cannot find in a Google search. His wife is an OB-GYN, he has twin 7-year-old boys, his father was a community psychologist, and his mother was a nurse practitioner. Now, I'll let him take it from here. So for everyone, Dr. Duncan Maru.
It's a real honor and a blessing to be here today. This is my first time in Nebraska, and I wanted to start by seeing anybody in the room who could pose a question or a thought that they would like me to address today, or why you're here and what you'd like to get out of my talk today. If I get maybe 2 or 3, and just say your name and where you're from. Don't make me pick on you. Yeah, go ahead.
I'm Debbie Tomac. I'm a general pediatrician, but also the member of Healing Cottage, which is a nonprofit that is building a hospital in South Sudan. My question to you is twofold. First is, how do you connect with the local business health folks to partner with them when you are not like them? And the second question is, how do you connect people locally here with the mission and the healthcare service that you want to provide in that distant location?
That's a great question. I'll definitely touch on a number of those. Any other ones from the audience? Thank you, Debbie. Anyone else? Can we get a second-year Creighton medical student to ask a question? I'll haze you now. Did I see a hand? Go ahead.
Hi, Elizabeth Null, second-year Creighton medical student.
Excellent.
Got your wish. My question is more if we could kind of explore how you follow ethically best practices with the work that you're doing abroad. Really touching on, if you collaborate with other health professionals who specialize in healthcare ethics, or sort of what you do in that arena to ensure that is being followed through.
That's a core. That is a core question. I'll definitely touch on that. So, my requisite, I have no financial conflicts of interest. I certainly have numerous cognitive biases that hopefully you will tear apart in the discussion and session and thereafter. So I actually, as I mentioned, this is my first time in Nebraska, and I have to pay 2 minutes homage to my ancestral home. This is the small boy is my grandfather, Denzel, who is the son of farmers in the Lincoln area. He went to Lincoln College and ultimately graduated with a PhD. He was the first person in my family to graduate from high school. He ultimately got a PhD from here at the University of Nebraska, and subsequently went on to work with the U.S. Navy and in government for many, many years. And so in honor of that, I thought I would just pay tribute to a few remarkable Nebraskans that that provide some guidance for us even today, even 2 centuries since they were born. Dr. Matthew Ricketts was the first African-American physician to graduate from Omaha Medical College and the first Nebraskan African-American state legislator. He was born just on the eve of the Civil War. And Dr. Susan Picote was born on the Omaha Reservation and was the first female Native American physician. And I really wanted to actually make a pilgrimage to the Walt Hill Site Memorial Hospital, which is now a historic landmark. And it was the first Native American hospital that was fully autonomously funded from the U.S. government. And finally, Grace Abbott, who was born to the west of here in Grand Island and was a teacher and a social worker and one of the authors of the Social Security Act of 1935. She was actually the first woman nominated to a cabinet post to the Department of Labor. And so I think our 3 Nebraskan heroes remind us that when we're talking, today I want to talk somewhat about healthcare delivery systems and to touch on some of these questions of how do you deliver care in an ethical way, in an effective way, in an affordable way. And when we do that, this is a deeply technical problem about how do you organize teams, how do you organize healthcare workers, how do you train them, but it's also within a broader historical and social context. And so whether you're working in Omaha, Nebraska, or you're working in Acham, Nepal, you have to appreciate and understand these deep histories that shape really who lives and who dies and when and how they receive their health care in between. And so Dr. Anthony yesterday brought up some wonderful quotes from Dr. Martin Luther King, and I thought this is a quote that's spoken to me as I have navigated my path in social medicine about the deep role and relevance of a certain particular history in our own country. And I'll quote here, "If it may be said of the slavery era that the white man took the world and gave the Negro Jesus, then it may be said of the Reconstruction era that the Southern aristocracy took the world and gave the poor white man Jim Crow. They segregated Southern money from the poor whites. They segregated Southern Moors from the rich whites. They segregated Southern churches from Christianity. They segregated Southern minds from honest thinking. And they segregated the Negro from everything." And that really speaks to the vital role of history that has played in the lack of justice and lack of health in so many of our populations. And this is actually, you all saw in Dr. Anthony's talk yesterday, the differences in mortality across different segments of our population. And this was a really remarkable epidemiology study from about 9 years ago that statistically looked at can we group different constituencies according to mortality trends and then identify differences. And the very tragic and notable result, and this is, again, is sort of deep as one of the themes of health equity here, is you see that there's dramatic differences on the order between some groups of 15 or 20 years in life expectancy. And that is shaped by race, it's shaped by geography, and it's shaped by income. So as I shift now to Nepal and to and reflecting in the context of this conference on our role as physicians, as clinicians, as scientists, as advocates in global health, to consider the notion that that charity without historical analysis is dangerous and on the flip side, that self-reflection without social action is useless. And that we, as we go about our work, we have to, again, as Father really eloquently said, deeply discern what it is our motivations are, how those have been shaped by the cultural environment and histories of our own peoples and our own lands as we seek out to help and work with other communities in other places. And again, those other places could be within our own country, right down the street, but in communities that are fundamentally different from those communities in which we grew up. And so the question, a core question as we go about developing global healthcare systems is how do we afford high-quality healthcare that can reduce health inequities, and can lead to greater gains in health outcomes. And you all, many of you, I'm sure, are familiar with the Preston curve, which describes a relationship between income, and in this case, at a country level, and life expectancy. And you can see here that a number of developing countries are both poor and suffer from ill health, and that a number of wealthy countries, most notably the United States, actually lag behind a number of equally wealthy countries in their health outcomes. And that is shaped a lot by our particular histories of social and economic exclusion, but it's also shaped by how we deliver healthcare systems. And we have, and if you were to look at a different version of the Preston curve where you track life expectancy by healthcare expenditure, you see a very similar pattern here, where the United States lags behind other countries despite spending a significantly more amount. And so that takes us to Nepal. Again, that's this core question of how do you afford and how do you deliver high-quality healthcare is what I've been working on in Nepal for the last 10 years. And as background, Nepal is a landlocked country that borders, sandwiched between the two world's largest countries, India and China. It's about 30 million people, about $20 billion per year in GDP. Geographically, it's about 56,000 square miles, and for comparison, the state of Nebraska, which I just learned, is the 16th largest state in the country, and it has a square mileage of about 77,000. So it far exceeds the size of Nepal, and for its in that size, it has about 1.8 million people and a GDP of $80 billion per year. So the country is quite dense, although it is almost 95% rural, and it is incredibly poor. It's also incredibly diverse, with 123 language officially spoken. It's a highly non-diverse economy of agriculture, tourism, and remittances. It really as the largest share of the economy. It is also one of the world's newest democracies, having sustained a deadly civil conflict from 1996 to 2006 that ultimately overthrew a monarchy that was centuries old and ushered in what is now a federal republic. After the earthquake in April, the political stagnation that it had suffered since the Civil War finally ultimately resulted. People came together and they signed a constitution that includes a very progressive provision of the notion that the state shall bear the cost of health care for its citizens. And in environment where you have extreme poverty, a highly non-diverse economy, in a landlocked country, you have this opportunity to leverage newly democratic institutions to better deliver core public services to its citizens, and that's so in our fields, it's we're talking about healthcare. And just for some future context, I just highlighted to the west is where we have been working for the last 10 years. It's about 30 hours from Kathmandu, and to the east is where we just started since the earthquake. So the core challenge that we're trying to address as a healthcare delivery organization is to meet the needs of the citizens of Nepal and their healthcare by increasing public sector investment in health. Right now, globally speaking, the global average is around 60% of healthcare expenditures are via public spending. That's actually the United States is somewhere in that realm between Medicare, Medicaid, the Indian Health Service, and the Veterans Administration. And in Nepal, for a number of reasons, that number has lagged behind. And that gap is met by a wholly unregulated fee-for-service private sector in which the primary business model is that you come to the doctor and whatever you are prescribed, you have to pay money for, and that introduces a number of problematic health-seeking behaviors on the part of patients and problematic prescribing behaviors on the part of the clinicians. And so when we're thinking about how do you pay for healthcare and how do you deliver healthcare, the construct of affordability is crucial. And affordability is we could have an entire course on this slide. Affordability is a highly contentious topic in economics. But here, I want to sort of simplify it and talk about it as the government's ability to pay, and that is determined by various tax revenue, and in the case of Nepal, a substantial amount of foreign aid, over so the operational cost efficiency, which is the expense for a given healthcare deliverable. So if you're trying to take care over the course of a lifetime of a patient with diabetes, how much does that cost, and can you get the same outcomes at a lower cost? And the testing ground for this has been here in Acham. Like I said, for most people, it takes about 30 hours to get from here to Kathmandu, and which is really where all of the political, social, and economic power is concentrated in the country. Again, a long-standing relic of a centuries-old feudal monarchical state. And for myself, it takes about a 1-hour flight and then a 10-hour jeep ride. And this is a government hospital that was abandoned, had been actually abandoned prior to the Civil War, and continued to be abandoned throughout the Civil War. And when myself and my colleagues came to Nepal in right following the time of the peace accords, this was presented to us as an opportunity to work with the government to have resurrect the hospital and have it under independent management by a non-governmental organization. And it's been and ultimately we signed a public-private partnership contract with the government to manage this, and we've been doing that for the last 9 years. And so I want to just overview the contractual framework that we have with the government, and this actually required cabinet in 2009 to authorize it, and that required a substantial amount of lobbying with local politicians and relied upon a number of citizen activists from Acham, including our founding medical director, who was one of the first physicians from this district to be trained in medicine. So the facilities are leased to the nonprofit. And I should clarify that the nonprofit, legally speaking, the nonprofit is a Nepali non-governmental organization with a Nepali board. And we have an additional 501c3 tax-exempt organization based in New York that works together with that organization. We have a single org chart and we function as a single team. And but legally speaking, all of the fiduciary responsibility on the part of our healthcare delivery teams, it really is borne by the nonprofit board in Nepal, and all of our employees are Nepali citizens. So the government provides these in-kind resources because the government throughout the country has this built but underutilized resource in the form of facilities. Then we structure our contract around a independent management. I should say, probably correct myself in saying it's probably independent management together with government, in the sense that we have a number of management boards on which local government officials sit, and the government is expected to regulate us and hold us accountable to high quality care. But this piece is very important to us because we need the flexibility to innovate and to create the kinds of management systems that we feel are necessary for the kinds of the kinds of care we want to provide. In Nepal, there's centralized procurement from the government, so so the government provides their essential medicine supply chain. Again, this is another very rich topic, but the bottom line is this is, again, in-kind resources. And then over the course of time, we've negotiated various forms of co-financing, which is in which the government provides actually cash for us to provide services, but it's co-financing, and similar to how say Creighton or Brigham Women's deliver healthcare in America, where you have a mix of Medicare, Medicaid, government providers, you have a mix of government grants, for example, NIH, and then you have a number of private insurers, and you have philanthropy. Healthcare is fundamentally requires this sort of diverse stream of revenue, especially if you're in the innovation and academic space. So we're not looking to be 100% funded by the government, and we wouldn't actually want to be. And finally, operated and regulated on a population-based manner in which we are held accountable not to the number of X-rays we perform, the number of outpatient visits we provide, but on how we care for populations of patients. And I'll just say that in our case, we've worked out over the course of time, thinking about the district healthcare system, which includes like a hospital, like I mentioned, smaller clinic-type dispensaries, and community health workers. We've worked out over time a number of, or 6 key performance indicators on which we base this contractual framework. And they are supposed to be representative of a broad swath of what we're trying to deliver in public sector healthcare services. And they include access to surgical care. We have an equity access metric, which in the Nepal context, because of a longstanding caste system, we actually use caste as our proxy for overall healthcare access disparities, which actually has some limitations, but we felt that in trying to optimize our systems and the regulatory framework to sort of key performance, we thought that having a metric around equity was important. Safe birth, which is effectively the number of women the percentage of women who deliver in an institution, a healthcare institution with a trained provider. Chronic disease control, because there's a growing burden of non-communicable diseases throughout the world, and we have a particular chronic disease control metric. Outpatient utilization, which looks at the overall coverage of our primary care delivery at the village and community level, and a metric around family planning. So thus far, just to make concrete sort of what we have done with this public-private partnership, currently we treat about 70,000 outpatients a year, about 2,000 inpatients. We have with a CHOM public-private partnership, we have 130 full-time public sector employees, and an integrated care delivery system via 13 clinics in a hospital and 165 community health workers. We have a family practice residency and mid-level practitioner program that works in partnership with the National Health Training Center, which is a government entity, and the National Academy of Medical Sciences. And we felt that it was necessary for us to invest in digital systems. And so the government has committed to nationally to an open MRS based healthcare system, which is a particular platform that is designed for settings such as Nepal, and we have deployed that. That went live February 1st of last year, so it's been going on for about a year, and we are working to scale that as a national program. That also, incidentally, is how we do government reporting, surveillance, and it is the backbone of our implementation research platform. We also have, in a population of about 1.5 million, the only public sector orthopedic surgeon. So that overviews some sort of a little bit of what we've done in CHOM. I put this slide up just to emphasize that if you're going to have a public sector strategy, revenue strategy, then you have to have a very strong government affairs team, and that happens at both the national level and the local level. And so we actually have a department within our organization that we call Governance and Partnerships that is more that you all may be more familiar with as a government affairs or lobbying team, and it is a core part of how we advance our partnership with the government because our government affairs team literally spends day in, day out with the Ministry of Health identifying policies to change, for example, around the deployment of digital healthcare systems or performance-based financing agreements, or what do community health workers look like in Nepal in the next 2 decades, or how do you control non-communicable diseases, and working on that policy framework environment at the same time as they really hustle to sign contracts with the government that are on favorable terms for our organization and which represent a real-life implementation of what we see as good governance and vital to healthcare transformation in Nepal. And at the national level, you have a number of different ministries. The Ministry of Health, of course, is the primary one. Ministry of Finance is critical if you're going to get funding. And then National Planning Commission. Additionally, we work very closely with the parliamentarians, and they are central as elected representatives of these communities to getting these governments, United States Aid for International Development, USAID, the German, and then German and British and Australian and other counterparts. And we'll talk some more about this in one of the later panel discussions today. And so a core strategy over the last several years has been, for the government, it has made a lot more sense for them to sign contracts around around hospitals. And what we really want to do is not only take care of hospital-based patients, because you can imagine that if you center your entire business strategy around a hospital, you're going to, over the course of time, potentially be incentivized to bring more people to hospitals as opposed to treating them in smaller clinics or in their own homes even. And so we are very attentive to these kinds of incentives, and so we've been working on developing what some people have termed an accountable care system, which borrows from the language of accountable care organization in the United States, which came about in the mid-2000s, where you define your population. In our case, we're defining it as a rural district of, say, 260,000 in Acham. You define population level metrics such as the percentage of women who are delivering in a facility with a trained provider. You create systems of continuous improvement where you have learning and quality improvement built in our case, critically in digital systems. And again, as a number of organizations in the United States have basically chosen to invest their business model and their care delivery system in quality improvement, the most prominent case perhaps being the Intermountain Health System in Utah. We have said that we believe that the long-term interests of the healthcare system are best served by integrating quality improvement and learning into those. And then payments and incentives. Currently, we have, as I mentioned, that contractual framework. It's vital that the country moves to some sort of national health insurance model, which does not exist. There is no Medicaid or Medicare in Nepal. And there's no private insurers in Nepal either. So everything is either free point of care government or user fees at the point of care by patients. And then finally, that you have some form of coordinated delivery. And again, this is where digital systems are incredibly vital. And the complexities inherent in the interoperability between clinics and hospital systems and of course, internet electricity in settings such as Acham are deep and again, certainly a talk for another time. So I just want to highlight that again, attending to our public sector business model, we work very closely with the government, and one of the key questions right now is how are we going to, how is Nepal as a country going to roll out national health insurance? And Cabinet, a couple years back, actually authorized approximately $90 million, which is a lot of money in Nepal, to the health insurance scheme, but the implementation of it has been very slow and troubled, and we've been working closely in trying to make that a reality. But this is of deep interest to us because I think in the long term, this would be the core revenue stream above and beyond the individual contracts that I was just mentioning. And I wanted to just, it's not, all of you are very well aware of the devastating earthquakes that happened April 25th and May 12th in Nepal. I happened to be in Acham at the time. We were having, actually, because our annual budgeting, we are on the July fiscal year. We were having our budgeting session there with our leadership team when it happened, and it was a deeply tragic event for the country in which nearly 9,000 people lost their lives. And so we were all there, and I just want to speak to briefly how we went about, how we thought about this as an organization, again, attended to our overall public sector strategy, because it's very challenging in the heart when you're in the middle of a disaster to think rationally and to think where can I truly help, and where am I potentially intervening for myself rather than for those who have just lost so much. And so we did not engage in direct relief efforts. That was actually very easy for us to say, because we are not a relief organization. We're a long-term health systems organization, and we knew that it was going to be faster for any of our teams to get to Kathmandu. It was actually easier to get from San Francisco to Kathmandu than it was from Acham to Kathmandu. We directed donors to other partners. We did spend, myself and some of our members of the government affairs team did spend a significant amount of time eventually making it back to Kathmandu and working with the government as far as supply chain. There were a number of donors that we channelized to a number of our Nepali healthcare organization partners, and including a really wonderful partnership with Direct Relief, who channelized all of their well over $10 million worth of equipment through government chains. And then finally, we did say that the earthquake represented a fundamental event for the healthcare system, and we had to engage in the long-term health systems building process. For lack of time, I won't get into it too much, but we've been engaging with the government around rebuilding of 21 health facilities there, and then we just started a similar public-private partnership at a really beautiful government hospital that had taken 5 years to complete at the request of the local communities, and was empty during the time of the earthquake, and actually it sustained no damage. It was built very well, and we just have initiated services at this hospital where, again, under that same public-private partnership framework, and going to be using it as another hub of innovation and training and teaching in the public sector. So for lack of time, I won't get too much into implementation research. I'll just say that another core strategy that we do is implementation research, and indeed that's how my work with Possible is funded via the NIH. And so I want to, and we do a number of different pragmatic trial methodologies for that. But I wanted to sort of take the last moment to see if there were any other questions. And we have about 7 minutes, so I want to take maybe 3 questions, and then I'll try to answer them all in a batch. So raise your hands quickly. Go. Oh, yeah, great question. All right, next one.
How are you not perceived as the outside consultant who comes in and tells people to do what they're doing?
Yeah, that's a great question. And that actually plays into some of Debbie's questions previously. Yeah, go ahead. That's a good question. Any other final questions? Any burning ones? Yes, sir.
What's the situation with the Maoists and the rebels?
Okay, that is real. Good question. All right, final question. Go ahead, Jason.
Duncan, thanks for your time. I have a question regarding what you said. A lot of your funding comes from NIH, who's your research. Do
excellent question. Yeah. That's brilliant. Yeah. And so let me tackle this question together with the outside. So I have about 5 minutes to answer these questions. This Civil War will probably only take about a minute. So, so this question of, and I've been back to Debbie's original question and thought about sort of how do you engage local businesses. I want to be clear that this is very difficult. It's critical to our organizational brand that we present ourselves, we lead ourselves as a non-governmental organization, a Nepali non-governmental organization, not as an international non-governmental organization. And so that's why again, the government never sees money or really interfaces with the 501c3, even though the 501c3 is very, which is the United States-based entity, is very integrated with the team. All of our contracts are, and again, sort of this question of who is part of this government affairs teams. Basically, the government affairs team, to summarize it, are Nepalis, young Nepalis who ultimately want to go into politics. I would say that's sort of the basic cadre of our government affairs team. And the reason why that's important is that it is very hard to work in government affairs. Literally you're going from official to undersecretary to joint secretary to secretary to minister to across the road to the Department of Health Services and back to the Ministry of Health. And it is such a long game, and it really requires this sort of like equanimity and peace. And our government affairs director is this amazing at it. He's a lawyer by training and worked in the health sector for a long time. He ultimately wants to be a maybe I shouldn't say this, but anyways, he wants to be a politician. He does want to be in long term, he wants to be a politician, but he's leveraging this experience right now to over probably the next several years. He doesn't want to be a politician for about 10 years, but to develop his understanding of governance in Nepal, of how the government system works, and how to better actualize government bureaucracies for the right to healthcare. And so the question of the outside consultant, it is frequent. It's always there. But the main part is that one, our Nepali government, I'm not the front man, and I wouldn't be a very good salesman in any case. Our government affairs team is all Nepali, and our board is composed of Nepali business leaders, of journalists, of healthcare leaders, of folks within the broader kind of public sector advocacy apparatus, and so it really is the brand is really, we try to drive the brand based on that on those individuals. As far as the conflict between that said, it's very difficult, and we are frequently seen because of people like myself as an international non-governmental organization, and that's really damaging to our long-term prospects. As far as the NIH question goes, the NIH, the particular mechanism that I have is it's called the Early Independence Award. It's from the Director's Common Fund. It's amazingly flexible. The program officers are just so wonderfully supportive, and it's again it's a wonderful example of sort of government science funding done really, really well. So there's not really pressure from that side. There is a definite conflict between how do you design scientific data systems and how do you design data systems for healthcare providers. And we have chosen organizationally, and you can only optimize anything, in the true sense of the word optimize, you can only optimize anything for one audience. And so we've chosen strategically to optimize for the healthcare workers and their managers. And then we have to work from the the electronic health record data system that we have and the rollout of various services to generate data and analyze data that are good enough to help make policy decisions. So we're not right now running randomized controlled trials. I think that they would, in our particular trajectory as an organization, they would be both unethical and infeasible. And so we are doing much more very pragmatic research. And it does remain to be seen whether scientific funders like the NIH or journal editors, how appealing some of our methods and our results are to those. And finally, on the civil conflict, I would say just maybe come after and we can discuss some more. But I do think that there's, among the refugee populations here, it's certainly was a traumatic experience, and it's worthy of sort of gaining some insight into. And I'm sure I have some colleagues who would be very interested in providing some guidance on that. So I think I'm out of time, and I just want to thank you all again, and I look forward to the panel discussion the rest of the day. And please reach out if you have any other questions or interests to share. Thank you.